And hi, everybody. Thank you for giving up your evening, or at least an hour of your evening, to think about PMDD. Hopefully, today, what we're going to do is go through what PMDD is, think about sort of symptoms, diagnosis, and treatment, and how we can manage this. And I'm certainly talking predominantly from a primary care perspective. But I mean, obviously, I understand that there's going to be other clinicians in the audience tonight, but we're primarily thinking about how we might be able to manage this in primary care as GPs. So I don't have any disclosures to discuss tonight. So what we're going to do is really think about what PMDD is, where it comes from, what causes it, what are some of the symptoms, how we diagnose it, and what the sort of current evidence-based treatment is. And I'm aware that there's lots of different treatments out there, but what does the evidence actually say? For the purpose of this presentation, what I'm really going to be referring to is women and individuals assigned female at birth, but I'm really referring to cisgender women tonight. But I do recognise that PMDD is obviously going to affect anyone who menstruates, and it can affect people of gender diverse identities too. So I just wanted to sort of make that point because I'm aware that, we often talk about this really relating to women, females, and we need to be mindful that others might also suffer as well. So PMDD, what is it and what is the prevalence of it? It's actually much more common than many people realise. And actually in the UK, around 1 in 20 women or menstruating individuals may be suffering from it, which equates to just over 1 million people here in the UK. And actually we know that PMDD can have a real profound impact on mental health and daily functioning. So symptoms aren't just what some have referred to as mild or worsening PMS. For some individuals, they can be really severe, disabling, and of course, as we know, associated with suicidal distress and indeed suicidal thoughts. We do know that those that suffer from PMD at a higher risk of suicide in general. And this can be really tricky to manage in primary care, can take up a lot of time, which we don't necessarily have, but it's really worth remembering that those with PMDD do really, really suffer. And importantly, we know that individuals often wait around an average of 12 years before receiving an accurate diagnosis. Many have gone through multiple different treatments and not really been told what's going on with themselves. So obviously that delay can have quite significant consequences in terms of quality of life, in terms of employment, mental health, and ADLs in general. So when we think about PMS and PMDD, they're often sort of terms that I hear referred to as PMDD being a worsening of PMS, but they're really two very distinct clinical diagnoses that differ in severity. Some of the symptoms are very similar. So PMS typically involving some physical and emotional symptoms, really common bloating, headaches, irritability, mood changes, particularly in the luteal phase. But PMDD is much, much more severe, and of course, it's formally recognised as a psychiatric disorder. And what we know is it involves really intense mood changes, really severe depression, anxiety, anger, irritability, really significant emotional dysregulation that significantly interferes with daily functioning and relationships, as we said before. And actually, what we know is that PMDD is a sensitivity to hormone fluctuations rather than an abnormal hormone level. And this is a really important point because PMS and PMD aren't the same and they're not on the same spectrum, and they're two really different diagnoses. And really, we need to start thinking about them very, very differently and start to kind of really think about how we might recognize these in individuals. I think what we do know about PMDD more and more now is that it's not caused by abnormal hormone levels. Instead, we know that it's probably more related to an increased sensitivity to normal hormonal changes that happen across the menstrual cycle, and really importantly, in that luteal phase. So we know that there has been various research papers that have been published that have identified genetic differences in women with PMDD that affect how their brains might regulate emotional processing, for example. And these differences appear to make a really big difference in terms of our sensitivity to fluctuations, particularly estrogen and particularly progesterone. And those normal hormonal shifts can actually really trigger significant mood symptoms. So we know that symptoms occur in the luteal phase. We know that in most people, those changes don't necessarily cause any problems. So we know that that GABA activity is generally not as sensitized in people that don't have PMDD. For PMDD, those changes in hormone levels, particularly the rapid drops in progesterone, rather than the actual level itself, can also trigger symptoms. So it might explain why simply supplementing progesterone alone is not always an effective treatment and not currently in the guidelines. We know also that another key factor is the involvement of the metabolite of progesterone. So we know that as allopregnanolone, which is that neuroactive metabolite of progesterone. And normally, what we know about allopregnanolone is it's beautifully calming, isn't it? It has those calming effects by enhancing GABA signaling, by reducing anxiety and stress response. But some individuals are particularly sensitive to those changes in allopregnanolone. So rather than actually producing a calming effect, paradoxically, in some individuals, it can actually worsen symptoms. So we're just bearing in mind that there's a vast array, a spectrum, if you like, of how this might manifest, why it might manifest. And then, of course, we've also got to think about, PMDD, luteal phase responses, and how things like inflammatory changes in the body, differences in how we process and store information related to emotional regulation has an impact as well, and of course, genetic vulnerability. We also really know that there are going to be environmental influences, so stress, particularly trauma history. If someone's had a history of a traumatic event, that is a key indicator and a key sort of part of their history we need to be recognizing. Smoking and existing mood disorders we know may increase risk or further or worsen symptoms, for example. So actually, what it is it's going to be many different things that cause symptoms. There's going to be genetic vulnerability. There's going to be changes in hormone levels. There's going to be changes in the brain structure and function, how we each individually respond to these changes in hormone fluctuations that are occurring. So it's a bit of a puzzle because on the one hand, you might have somebody that really is not as sensitive to that metabolite of progesterone, allopregnanolone, as somebody else. And that kind of leads us on to thinking about how treatments might work. So overall, we know that PMDD is really understood now to be kind of much more of a neurobiological, neuroendocrine disorder involving a degree of hormone sensitivity, involving brain signaling pathways, genetic vulnerabilities, and susceptibilities, rather than just a fundamental hormone imbalance. And I think that's really key for us to remember because it also is really key to remember in terms of what we do for treatment. So why is it important for us to recognise and to appropriately diagnose? Well, we know that the economic impact of PMDD is quite huge. There are a lot of stats out there, and these, a huge number of statistics on PMDD, but we know that the toll of PMDD goes really far beyond the physical. We know that many face medical burnout. They keep coming back and trying to kind of clarify what's going on. They may feel quite hopeless. We know that work absence is significant. 40% are more likely to miss work to their PMDD symptoms. We know that 27% are more likely to be unemployed, and we know that there is significant relationship difficulties. I'm sure we've all had individuals that are struggling at home in the luteal phase or who don't recognise themselves in the luteal phase because they feel like a completely different person. And that often leads to kind of lost productivity, mental health crises, career disruption. I mean, the list goes on really, doesn't it? So thinking about the socioeconomic impact of PMDD, I think is also really valid as well. Because I work primarily as a menopause specialist, as many of you will know, as Jenna knows, I couldn't really talk about PMDD without really touching on kind of that broader concept of reproductive depression, what we call reproductive depression across our life course. And PMDD, as we've said, is fundamentally a reaction to an ovulatory menstrual cycle. So it means it only occurs when we're menstruating, when we're ovulating. But the symptoms and the degree and how they present will vary, I believe, across different life stages. So we know that PMDD can start as early as adolescence, as early as our first periods. And in teenagers, this can be really difficult to manage because it's often overlooked, I think. We often see, those first few years of someone's period as being that adjustment phase and teenage moodiness. But early onset PMDD is particularly disruptive because it obviously is occurring at a critical time for development, education, identity. And if this is a symptom that is there, it is difficult to identify, and that's the importance of education and education around what we should be feeling around our periods, I think, and not normalizing these significant mood changes and actually making people more aware to talk about it a bit better. So most diagnoses tend to occur a lot later. We know that, many people start to experience more cyclical symptoms and they start to kind of really recognize the pattern of their periods and how that make them feel in their 20s and 30s. And that tends to be when most women are diagnosed with PMDD. Um, it's also the stage which obviously overlaps with lots of other things that are happening, pregnancy, postpartum as well. And we know that with reproductive depression, many individuals are much more likely to suffer with higher risks of postpartum depression because of the way the brain is struggling with those dramatic hormone shifts after childbirth. And then we move on to perimenopause, this final flare in symptoms when we know that estrogen and progesterone are fluctuating really, really wildly, unpredictably. And for someone whose brain is already quite sensitive to those hormone changes, this can be a time when we would anticipate PMDD getting worse. And many describe perimenopause as that feeling like that second puberty and occurring when they're already managing, difficult life events as well. So I think we need to bear in mind and think about this really, really holistically. There's a really great report that came out from the Royal College of Psychiatrists a couple of weeks ago, which highlighted menopause and mental health. And there's some really good sections on kind of mood disorders in there and recognizing reproductive mood vulnerabilities. And I would really recommend reading that if you haven't already. And then obviously finally we reach the menopause, and often this is a time for PMDD sufferers where things start to stabilize a little bit. We're not ovulating, so that luteal phase has gone and we're not triggered in the same way as we were before. So what are some of the symptoms of PMDD? Well, to have a diagnosis, we've got a formal DSM criteria, haven't we, to meet the diagnosis. And I often I often find this a little bit tricky because when you've got someone that's presenting with all the symptoms, we often go back and ask them to track prospectively for 2 cycles, and that can be really hard for somebody that's struggling and has actually built up the courage to come and see us about something. So what we really need to be doing is obviously being quite mindful about people's symptoms and treating them as the expert in their symptoms. But we do need to be tracking their symptoms over two luteal phases, so regular ovulation. So to meet the diagnostic criteria for PMDD, what we need to do is have one or more of the first 4 sets of symptoms there present. So those effective symptoms, which have to really get a little bit better or resolve completely, either as soon as the period starts or in the few days of the period starting. And in addition to that, we need to be trying to pin down if they're having any other somatic symptoms that are listed there. And we need a total of 5. So 1 from the first group and 4 from the second, or a combination of those. And they have to be, as I said, happening on the luteal phase. It has to have an impact on functioning and ADLs, and it has to be across at least 2 consecutive menstrual cycles. So prospective daily symptom ratings are really recommended and really worth tracking. Again, I say this as the blue sky because this is really difficult to manage in primary care, particularly when someone's really, really struggling. We also need to make sure that we're treating people holistically, of course, and that the symptoms they're experiencing aren't better explained by another medical disorder or a psychiatric disorder. So whilst there's obviously clearly no blood tests we would do for this, we need to be thinking, is there another disorder or a metabolic imbalance here that might be predisposing somebody to symptoms that we could relate to something else? There's lots of symptom trackers out there, tons actually. I use EMIS Web in primary care, and so one of the things that I do is I use a symptom tracker from IAPMD, which is a great website. I'll put the link at the end. And I use that in my AccuRx. So I just text this to patients and ask them if they can fill this in, if they feel able to. Print it out. I have an LD patient friendly version of this. It might be a quality improvement project you could do within your practice. It's a really useful way of just kind of pinging this across to patients and asking them to track. It is quite labour intensive, so there is a kind of a little bit of hand holding that needs to be done, particularly if someone's really feeling terrible. That this is going to be beneficial for them in the long term, so that we can really kind of get to grips with what's going on for them and treat them appropriately. So one really encouraging aspect of PMDD is that there are treatments that we know are evidence-based and effective, and getting the right treatment may require a few adjustments. And this is where that supportive care really becomes essential, doesn't it? And I sometimes refer this to the stage as the hand-holding phase, because patients often need additional reassurance and follow-up and contact during this period. Certainly, some of my patients, my long-term PMDD sufferers, they are constantly at the surgery. They call regularly, and actually, it can be really helpful to touch base, even just for a few minutes with them, because we know that the waits for some of the other therapies, like cognitive behavioural therapy, which we'll come on to in a minute, can be really, really long. So I think we need to bear in mind that there are lots of different treatment options. We may have to try a few things, we may have to change a few things, but this really here is the gold standard of what NAPS, the National Association of Premenstrual Syndrome, recommends, and this is also taken from the RCOG Green Top guidelines as well. So first line, we know nutrition, lifestyle is really important. We'll come on to that in a minute. There's some evidence around B6 and some other supplements too. We also think about the combination pill, the combined pill, or SSRIs. Second line, we know about estrogen patches and higher dose estrogen patches, which we'll come on to. And third line, which I'm not going to go into a huge amount of detail today, because this is where I normally refer to my gynecology colleagues, thinking about GnRH analogues and add back HRT. And then finally, surgical treatment if symptoms are really intractable. So first of all, thinking about nutrition, I think there's a huge amount of evidence out there that nutritional strategies really do help with PMDD as a fundamental baseline. They may not be the only thing that we do, but they will certainly help. And they're largely aimed at supporting metabolic stability and neurotransmitter stability in the luteal phase. So as we know, and as we've said before, changes in those estrogen and progesterone levels can affect serotonin activity, they can affect insulin sensitivity, and they can affect our stress hormone response, which may then contribute to mood instability, fatigue, food cravings, bloating, constipation, all those things that we know PMDD sufferers have. So really the fundamental of nutrition, and again, I'm not professing to be a nutritional therapist here. I work quite closely with a couple of nutritional therapists to support patients. But encouraging regular meals with balanced nutrients is going to help maintain stable blood glucose levels, prevent those rapid fluctuations in sugar levels that can actually worsen irritability. And really, what we're looking at is complex carbs. So, this isn't rocket science, but actually, if you're patient, drilling down on these is really, really vital, because I think what we're often, and what I sometimes do is just say, do you think you eat well 80% of the time? What does that actually mean for that person? So are they having complex carbs to support all of these functions? Foods rich in magnesium, in folic acid, in omegas, so that we can help regulate all of these functions, inflammation and signaling pathways. And we know that that can be really helpful. We know that good nutrition can be really helpful, not just throughout the month, but really focusing in on that in the luteal phase, which again I know can be difficult when people aren't feeling great and just want to reach for that quick fix. Again, limiting caffeine, alcohol, all those highly processed foods we know can also really help and reduce fluid retention, which is one of the symptoms that can be exacerbated in PMDD. So we know that dietary approaches are really evidence-based. And this is where I feel that getting nutritional therapy support is amazing. So in a similar way to I say, women's pelvic floor physios are worth their weight in gold. This is where I think nutritional therapists come in as well, because I think even if you can ask your patient or refer your patient, I know that's difficult, and get them seen by somebody that specializes in PMDD, it's about this multidisciplinary collaborative approach to these patients. It's not just us working in isolation. Um, it's thinking about all the other ways that we might be able to support them. So we know, and again, this is from the NAPS guidelines, we know that alongside pharmacological treatments, complementary therapies have been studied, and there are various trials out there that show some improvement in symptoms based on various different supplements. B6 is one of them there, calcium is another, isoflavones mixed, but some evidence there. Agnus castus or chasteberry probably got the most amount of good evidence, and St John's wort, which we know is um, possible, but actually RCTs don't really support its use. So we know that many of our patients will be using some sort of supplement. They will come in, so it's worth us knowing about herbal treatments that they're using. Um, and I think probably looking at this table, Agnus castus is the most widely studied, probably acting through, we believe, dopamine pathways that influence prolactin levels and then sometimes can help influence serotonergic activity. But I guess the key thing, then, the worry for me is that I'm not proficient in supplements and I'm not going to confess to be or profess to be either. But supplement quality and formulation will differ, won't they? So we don't know what patients are using. And again, this is where maybe nutritional therapy might be helpful, and maybe really honing in on the diet to get that B6, to get that calcium is going to be important. Certainly, what I really recommend doing is supplementing with vitamin D if we can. We know that can be really helpful. There's quite a lot of evidence that those with PMDD have lower calcium levels and lower vitamin D levels. So it might be worth thinking about supplementation there. One of the things I commonly do is I ask people, or I do this with them, to fill out the calcium calculator score online. And many of us will be familiar with that in our perimenopausal and postmenopausal patients. But it can be a really helpful exercise just to see what level of calcium people are getting in the diet. We really want to boost that if we can naturally. And the calcium calculator online is great. The reason I do it with people is because it's quite tedious. It takes a little bit of time. And if I send patients away to do it, 9 times out of 10 they don't. So I generally tend to sit there and do it with them. So whilst these approaches kind of are adjuncts, we don't have huge amounts of evidence to say this is what we should be recommending. But as we know, our patients will be taking one or a combination of these. So SSRIs really do remain the one of the first line treatments for PMDD, and I think they have got a lot of bad press recently, haven't they, around the worry about them and tolerance of them, and do I really want to be on an antidepressant for this hormone fluctuation disorder? In PMDD, we've got a lot of evidence that they can be really effective and really effective at quite low doses and quite quickly. Now, I'm very mindful this is not going to be the case for everybody, but actually the evidence is that they can, if they're going to work, they can work quite quickly, and even low doses could be really effective. So I tend to start really low, go really slow, and adjust doses depending clearly on response and tolerability. So we know that SSRIs are really effective for affective symptoms, so irritability, low mood, anxiety, for example. But we also know that they do have a role to play in somatic symptoms as well, so bloating and breast tenderness. And one of the advantages of PMDD is the dosing regime. So we can use them just in that luteal phase. We can use them in a continuous manner, so all throughout the cycle. And actually, in people who have underlying mood disorders, sometimes what I do is do a continuous dosing, but bump it up a little bit in the luteal phase and bump it back down again when menstruation starts. And for some women, that can be really effective, and they don't get the negative effects from going sort of slightly up and down on this if we start low. So, for example, my go-to is escitalopram. I always have found that much more beneficial than anything else. And I would start at 10 milligrams continuously, maybe bump it up to 15 or 20 in the luteal phase, and then bump it back down. Um, and it can be really effective, and it can be really helpful for serotonin function as well. Why does it work? Well, we know that in some studies, as we've said before, PMDD patients have been reported to have reduced levels of that progesterone metabolite allopregnanolone. And so those that have lower levels are thought to be more sensitive or more vulnerable to PMDD. Now, again, this is not the case for everybody, because you could have normal levels of allopregnanolone and still have symptoms. So this is where it can be really difficult to individualize treatment, and why we might have to try a few different treatments before we find an effective one. But one of the hypotheses for the effect of SSRIs really is that the interaction of these medications may enhance the sensitivity of that GABA A receptor, and promote more formation of allopregnanolone, which generally tends to be our anxiolytic metabolite of progesterone, the calming hormone. But I am mindful that we probably all had patients where SSRIs haven't helped or made people feel worse, but they are another tool in the box. And then we have our combined oral contraceptives to manage PMDD. So essentially, they are working by suppressing ovulation and removing that kind of cyclical hormonal fluctuation and that dip towards the end of the cycle. The problem with lots of the traditional 21 7-day regimes is that hormone-free interval can cause ovulation to reoccur or symptoms to occur. So for that reason, what we generally tend to recommend is that 24-4-day regime, where we're reducing that hormone-free interval just a little bit, which can be more effective for symptom control. And the evidence we have really at the moment suggests that the drospirenone-containing pills might actually be the better progestin to use. So, example of that in the UK is Yaz and Yasmin, which all contain drospirenone in that 24-4-day regime, which reduces that hormone interval. And we know that from RCTs, this can be really effective in kind of suppressing ovulation and thinking about symptom control. We also know that the progestin is really relevant. So some of the older progestins can actually worsen symptoms, whereas drospirenone tends to be more anti-androgenergic and anti-mineralocorticoid. So it can have properties which may improve breast tenderness and bloating and those symptoms of irritability. Again, not for everybody. I'm sure we all have patients where we've tried these pills and it's made them feel worse, and we obviously need to be mindful of that. But it's something we need to consider. We also need to make sure, obviously, we're following UK Met guidelines, because this obviously won't be a safe or effective for every person that we see, but it's a useful option to have up our sleeves. There are some newer pills that have been developed containing estradiol valerate. So Clara is one of them in a phase regime, and Drovelis, which is the E4 estretol, if I can say it, combined with drospirenone. They are formulations that I would possibly use if I'm not finding other things effective, but we still have the best evidence base for those drospirenone containing pills. Slind is one of the new options many of you will be aware of, which contains 4 milligrams of drospirenone. When that's taken consistently and you avoid those placebo pills at the end of the packet, it can help suppress ovulation as well, and it can be good for mood stabilization. I think we can't really talk about any of this without really talking about the impact of GLP-1s in this whole picture. Particularly if your patients are obviously using COCPs for contraception. We know that many people are on GLP-1s. We might always not always be notified of this if they're getting it through a private online provider. But it's something I do ask a lot of. I do ask my menopause patients a lot of in terms of absorption of progestogens. And we know that GLP-1s may reduce that effectiveness of oral contraceptives. So it's just worth bearing that in mind as well. So thinking about cognitive behavioural therapy, I think again, CBT has probably got a bit of a bad press, unfortunately, but I think it can be really, really helpful, particularly as an adjunct to all the other therapies we've talked about so far, on its own as well, but certainly in a people with a history of trauma, which is a large part of my work. I find that CBT really, really helps. So when we have someone with PMDD, often we know that they feel that relief when menstruation begins, don't we? But this can quickly shift to dread about the next luteal phase. So instead of just feeling terrible and rubbish for 2 weeks of the month, what they're doing is they're feeling really bad in those 2 weeks. Their period then comes along and they start to feel a little bit better, and then they start to dread what's going to come. So actually, they're not just feeling bad for 2 weeks of the month, they're feeling bad for most of the month, which is why so many PMDD sufferers actually just have these suicidal thoughts because they are just dreading what's to come. And psychotherapy, I think, has a really important role to play in helping to manage symptoms, challenge those negative thoughts, and think about how to alleviate some symptoms as well by kind of helping people to improve communication skills with their partners, particularly with potentially occupational health, and having those conversations with employment as well. And I think it's kind of an adjunct, isn't it, to other treatments, so that we can really focus on helping to develop coping strategies for many people. So we know, as I mentioned very at the very beginning, that PMDD and the psychological symptoms that are experienced for PMDD can worsen in perimenopause. And again, that fluctuating in sensitivity to hormones might be the key here, alongside genetic susceptibility. But we do know that some people who have never experienced PMD can start to have PMDD-like symptoms in a kind of a reproductive depression type of way. So it's important to recognise that PMDD might present later, but if it's already associated with an increased risk of suicidal thoughts and self-harm, and we know that that risk increases as exponentially in the perimenopause as well. So highlighting the importance of recognition and appropriate support. And again, I know that this is difficult in primary care. These are patients that require a lot of time, a lot of appointments, and sometimes even just having frequent touch-ins with these patients can be really beneficial. But we do often need, again, that MDT approach. We can't just manage this on our own, and I don't think we should. I think we should be involving others too. So hormone replacement therapy tends to be obviously our gold standard as perimenopause, and particularly around the perimenopause, if someone's having symptoms of PMDD or worsening PMDD, it might be an option to use higher doses of HRT. And the rationale for that is that high dose transdermal estrogen can, or potentially can, suppress ovulation, and by suppressing ovulation, clearly we eliminate that cyclical hormone fluctuation. The sticking point here is that obviously we still need to consider a progestogen for endometrial protection, and micronized progesterone tends to be the one that we think of first line, utrogestan. Again, it's a bit like Marmite, isn't it? People love it or hate it, and whilst it has fewer androgenic side effects, we know that there are some women that just can't manage it. And that is when we might be thinking about using it in an off-license way. So maybe we're thinking about using it as a vaginal pessary. Again, not in current guidelines. We know that we can try and use it as part of a shared care discussion with our patients, and it might be better tolerated, but we do need to individualize treatment, and we do need to be mindful that some women are going to remain very, very sensitive to even micronized progesterone, which is difficult. Of course, we've got the Mirena coil or the Benelixir or the Levocert coil, and that is useful obviously for contraceptive purposes, but it can also be useful in individuals with PMDD if we are going to use higher doses of transdermal estrogen. But I think we need to be mindful that and maybe even counsel patients that even there might be even low systemic levels of levonorgestrel absorbed into the bloodstream, which can make symptoms of PMDD worse. And for some, um, it might not be an option. For some, it might be that they've tried a coil and they just don't feel that it's right for them. So overall, I think that HRT is a really helpful adjunct in some patients, particularly around the time of the perimenopause, when we're thinking about how to treat, perimenopause PMDD and think about long-term health as well. So GnRH analogues, again, not going to touch too much on this because by the time I get to this point, I'm either asking for advice and guidance from the gynecologist or I'm referring on. But we know that they can be helpful in managing really treatment resistant cases. So we know that they're licensed for uterine fibroids and endometriosis, but they are sometimes used off label to treat those severe cyclical symptoms of PMDD, and this is supported by the Royal College and NAPS, and they suppress ovulation function, don't they? So they effectively knock ovulation on the head, knock off the luteal phase, and stop those hormone sensitivities occurring. We of course need to think about add back estrogen and progesterone if we are using that, but typically this is done under specialist supervision in secondary care. So, in terms of treatment response, I guess the importance of this is to not only for ourselves to kind of be persistent in what we're trying, but also to be explaining this to our patients that it's not like HRT, a one size fits all, that we may need to try a few different types of treatment before we get the right one. We may need to adjust doses, stop doses, we may need to change timing, we may need to go from a luteal phase to a continuous phase, SSRI. We might even need to change the SSRI multiple times. I think cognitive behavioural therapy should be woven into all of this. We may find that hormonal contraception is good, is bad. I think it's a trial and error for many patients. HRT specialist review, and I've put spironolactone there because there is some evidence that diuretics might be helpful for cyclical symptoms and physical symptoms such as breast pain and bloating, but I've never really used it. I'd be interested to hear if anyone else has used spironolactone for these indications. I'm just mindful that there is that interaction between the combined pill and that theoretical risk of hyperkalemia. So I've never actually used it myself, but if someone has and has had good effects, I'd be keen to hear. And then really top 10 tips for PMDD in primary care and I guess secondary care as well is really the importance of tracking symptoms, which can be really difficult for patients who are feeling terrible. But tracking symptoms is really positive, so that we can really get a good diagnosis. Thinking about mental health support, thinking about how we don't necessarily need blood tests unless we're trying to rule out other causes of mood disorder, the importance of lifestyle measures, the importance of that nutrition advice is really, really key. Some people find that even just really honing in on that can be massively beneficial. We've touched on complementary therapies and the limitations of what we've got in terms of the evidence base behind those. SSRIs continue to be first line, really. And I think cyclical dosing can work, but I found that continuous dosing with bumping up the dose in the luteal phase can be really effective as well. And then in terms of where am I? In terms of resources, these are the ones that I generally tend to use. I tend to go to IMPMD, the PMDD Project for Patients. I think that's a great one. The Royal College Green Top Guidelines, the NICE Guidelines, and NAPS. And those are just some of the books I think can be really helpful for us and for patients. Unwell Women is one of my favourites, but these are some of the things that I would often use as my go-tos. And it's not you, it's me. PMDD can be a really useful resource for patients as well. And those are my references. Thank you very much.
Oh, thank you so much for that, Claire. That was so interesting. I'm sure everyone will agree with that. Um, okay, well, everyone will probably open it up to the Q&A section right now. So I will pause the recording. So thank you so much.